that I'm going to discuss about new paradigm of rectal cancer management. Most of my facts has been discussed in previous speakers, so I have to summarize these. Okay, these are my objectives. I want to explain concept of TNT for better tumor control and organ preservation, and what is the role of immunotherapy in rectal cancer management and ctDNA guide personalized management. Okay, traditional management of the rectal cancer usually is stage based. Early stage or upper rectal cancer, usually we do surgery, after that adjuvant therapy. Locally advanced or lower rectal cancer, we do neoadjuvant chemoradiotherapy followed by surgery and adjuvant chemo. But some limitations, high morbidity, permanent colostomy, all the patients are managed in similar way, no customers management, and limited response in poor risk group. So, total neoadjuvant therapy, this concept, deliver all the systemic therapy, either chemotherapy, immunotherapy, or radiotherapy before surgery. The rationale, early systemic control by killing micrometastatic and improve compliance. And you can increase pathological complete response. And if you want not to do surgery, if you have watch and wait, that's also possible in this setup. So few can key randomized evidence to support this trial. So I'd like to do FORTIGE-3 and Rapido and Opera. So what is the FORTIGE-283 say? The patients has been treated with 6 cycles of modified FOLFIRINOX, followed by standard low-cost radiotherapy, then surgery. After that, they have been given 6 cycles of FOLFOX, adjuvant treatment also. The control arm is different as a standard management like standard chemoradiotherapy, surgery and adjuvant chemotherapy. See the pathological complete response. Experimental arm 27%, control arm is 11%. So induction M4NX and chemoradiotherapy improve pathological complete response, disease-free sample, and in addition to now it's survival benefit over standard therapy. And we'll see what about the RAPID trial. This is also high risk local advanced rectal cancer. In this trial, the patient has been treated with short course radiotherapy. And after that, patient has been treated with 6 cycles of Capox or 9 cycles of FOLFOX. Then standard as management, standard arm is like same, like low cost radiotherapy followed by surgery and adjuvant treatment. Here, pathological complete response also double. So, Rapido regime is a very simple treatment, 5-day radiotherapy and short period of chemotherapy, but that even short period have given marvelous response with pathological response in addition to particularly is similar as like standard management. So long-term follow-up reveal no statistically significant overall survival benefit. The survival curve shows the 2 arms tracking quite closely. So these 2 trials, FORTIGE-3, so it's give over standard therapy, over standard management benefit. Overall survival is benefit more than normal standard management. Rapido, short period, you can get to same achievement. So something related MSI, MMR, these are mismatch repair gene, microsatellites are the DNA repair genes. When MMR is defective, nucleotide sequence become unstable, called MSI instability. If it is happened in germline, called Lynch syndrome, MSH high and defective mismatch repair, high mutation, but they are highly respond to immunotherapy. If it is low, they are poor respond to immunotherapy. Most of rectal cancer, immunotherapy can apply only MSI high or defective MMR or high tumor mutant burden. So this another true immunotherapy trial, MSKC phase 2 cohort, that's regarding dostarlimab in the patients who are with defective MMR gene. The 14 patients was locally Advanced rectal cancer patients were received neoadjuvant dostlam for 3 weeks for 6 months and show very high response rate. 100% clinical response, not pathological, 100% clinical response. All patients had no detectable cancer, even to the MRI, PET CT, or biopsy. No chemotherapy, no radiotherapy, no surgery. No, and side effects profile also acceptable. So follow up to now 2 years, no recurrence. So reported up to 2025, still no recurrence. So this result generate major interest, but the trial is small, but we need further studies. And another neoadjuvant trial regarding Pembro, neoprism, for colorectal cancer. This also population is high-risk rectal cancer patient. But this is colorectal cancer. The initial trial is regarding only rectal cancer. This is regarding colorectal cancer. Thus include rectal and colon 32 patients. They have given only 3 cycles of Pembro. And pathological complete response is over 50%. So this short period follow-up also still no recurrence. So very high pathological complete response. Who are the patient with defective MMR gene? So this support neoadjuvant, Pembro, or dostarlimab in potential organ preservation. But all the patients should be DMMR or MSI high. Okay, the comparison of these two trials. Dostarlimab, only 14 patients, locally advanced rectal cancer. But other trial, Pembro has given colorectal cancer, 32 patients. So surgery has been done on Pembro group, other group, no chemo, radiotherapy and surgery. The clinical response is 100% in MSKC trial and pathological complete response is over 50% with Pembro. Okay, if you get patient with colorectal cancer, defective with MMR, think about immunotherapy. You can get clinical and pathological complete response and will lead to organ preservations. And what about the metastatic rectal cancer? So Keynote 177 for metastatic colorectal cancer. All patients were previously untreated. So this is first line treatment. In experimental arm, Pembro 200 milligram every 3 weeks. The control arm as usual way in metastatic setting, Folfoxo, Folfiri, with or without bevacizumab. And assessment. After 5 years assessment, Pembro show low and medium progression for survival. And it is double compared to normal management and durable response. Long-term 5 years follow-up confirm durable benefit and superior long-term outcome in this setting. This established Pembro as a first line for metastatic colorectal cancer who are with MSI high. Okay, something regarding circulating DNA. So what is circulating DNA? Circulating DNA are the fragments of tumor that release into blood. You can see detectable only liquid biopsy. The circulating DNA assessment is now one of the most powerful tools in rectal cancer, colorectal cancer, because it can detect minimal residual disease and we can predict our recurrence risk and therapy guidelines. So it detects microscopic residual disease. You can much earlier than imaging or CEA. If circulating DNA negative, indicate you are in molecular remission. If circulating DNA positive, indicate you have active disease or high risk to recurrence. So this sensitivity is usually around 80 to 85. Specificity is around close to 90%, but it is low, the tumors with low tumor burden or mucinous histology. So this is a trial, again I am telling about dynamic trial. Initially this has discussed regarding adjuvant setting, because stage 2 colon cancer, most of time we stratify which patients need chemotherapy. Most of patients who have high risk factors only we give chemotherapy. In dynamic trial, the experimental arm chemotherapy only has been given to cDNA is positive group, and control arm, according to risk factor, they has been given to. So only 15% of cDNA positive patients giving chemotherapy in experimental arm, and 28% of standard arm. 2-year recurrence-free survivals are identical. So cDNA positive patients had very high risk if you are untreated. And the important point is here, cDNA can spare unnecessary chemotherapy, and we can identify only high-risk patient. Okay, in metastatic rectal cancer and colorectal cancer, you can monitor disease burden in different stages. Used for early detection of progression few months before radiological relapse or biochemical relapse. Detecting acquired resistance, can detect emergent DNA mutations or KRAS mutation, so in real time, and useful for rechallenging with EGFR or any other treatment after metastectomy or ablation treatment. So you can decide by circulating DNA whether patient need any adjuvant treatment after that. So these are my take-home messages. Giving all chemotherapy and radiotherapy before surgery improve compliance, tumor response, and reduce risk of distant metastatic. So total neoadjuvant treatment also open door for organ preservation who achieve complete pathological response. Who are with MSI high or defective MMR can use immunotherapy in neoadjuvant setting, achieve dramatic response, and help avoid chemotherapy, radiotherapy, or surgery. So, and cycling cDNA used for early detection of progression, predict recurrence risk, can spare unnecessary chemo, and identify this chemo only for high-risk patient. Pembro monotherapy is established as a first-line treatment for metastatic colorectal cancer who are with MSI high or defective MMR. Okay, thank you very much for your kindness.